Okay, well, since I brought it up,
Go ahead, Barry.
I mean, the similarities have to do with you know, the perhaps medical care or the scientific backbone of what we do, which would be the visit schedule and the labs and the discussing about sonograms and things like that, measurements and listening to the baby's heartbeat. But the average obstetrical visit is 7 minutes. And so we talk about a lot about what we do with the other 53 minutes of our prenatal visit. And so that starts with talking to our clients on the first visit about who they have in their life to support, what their relationship is like with themselves and the world, and how they make decisions is an essential piece of prenatal care, because they'll be going out into their own lives as parents and they'll have to make a lot of decisions. So those are the two big things, community and decision making. And so even if you have something like, do you want an anatomy scan, for example, you know, everybody gets the little picture up on their refrigerator. We talk about, why would you want it? What would you do if you got a false positive? How a false positive has been shown to impact a family's consciousness for 5 years after the false positive. You know, why would you get this? What would you do with the information? And although all of that is around the example of the anatomy scan, it helps them to hone their way of discussing with each other. It also really leads to bigger things. Like we had a couple where he really wanted the sonogram. He did not want a sonogram, and the pregnant wife wanted the sonogram. And it ended up where he spoke a lot about his cancer care as a teenager and how it had really frightened him, and he was afraid. And so it opened up this phase in his life for him and his partner that would have never have gotten addressed perhaps before this. I mean, obviously she knew he had cancer when he was a kid, but she didn't really understand the depths of it and what he felt like to be poked and prodded, and things were done without his permission. And so we were talking about how they make a decision and how they will make decisions about their kids. So that would be one example of how, you know, the myth is that it's all about the labor, but it starts really with the first prenatal visit to develop the couple or the family or whatever word works for people, so that they can be fully present and for the child that's coming into this world.
Thanks, Barry. That's great. Just like for the other midwives that are here, does anybody want to add anything to that? Because I actually, now that you're bringing it up, Barry, I mean, when I think about it, yes, I as a midwife, I've definitely done my share of many-houred births, right? But think about how many hours we spend with our clients prenatally and postpartum, and how different the care is because of that. Does anyone want to add to that?
I actually did. It's one of the things also that we're privileged to have, because we are able to spend an hour with our clients, is the ability to focus on health promotion, focus on actually truly talking about the things that make us physically and emotionally and spiritually healthy. Whereas in busy hospital practices, often people are given just things to read at home because they don't have the time. So I think one of the biggest things for home birth is that we are actually able to, and we have an agenda for every visit of things that we like to educate our clients on, the things that we often see come up emotionally for women during that time in their pregnancy, or the things that start showing up physically, like sugar cravings in the third trimester, closer to the birth. And once we mention it, like, oh, usually this is, we hear people talk about at this time that they're just craving cookies, and they're like, oh my God, now that you said it, all right, let's talk about it. So that's a big part of it also, to really, because we are with women for such a long time, we do hear about their environment, their ins and outs, their emotional like arcs, and in pregnancy, and the things that they're experience physically beyond the things that um, like round ligament pain. Everyone knows about that. But because we spend so much time with our women, we're able to be with them more and really able to distinguish what things are and diagnose things properly, but also focus a lot on being well and not just treating disease, which is important.
Thanks, Katerin. That's awesome. One of the things that is any other midwives want to add to that before I change the subject? And good. Okay. So,
I had my hand up.
I thought you might.
No. Oh, Tanya, I had my hand up. Martine,
you
did you want to talk?
Oh, just, you know what, guys? It's hard for me to say mute. Just like unmute and start talking. That's good.
Okay, sorry. So it's kind of on the same topic, but it's a little changing it too. And it's going to sound contradictory. So I'd like to say one of the biggest difference between home birth and hospital birth and even birth center birth is that home birth midwives don't have to follow the same protocol as hospital and even birth centers, right? So large institutions have protocols that is what they've decided is best practice for their catchment area, right? So the people that generally would come to their hospital. And if there's deviation from that, then you have to follow a certain protocol. Even the most hotshot doctor or midwife in a hospital, and it's not even birth, it could be a heart doctor, it could be a liver transplant, they don't have a lot of leeway, right? Home birth midwives, we know what those protocols are because we've either worked in hospitals or birth centers, or we've been schooled and we've been taught and we've been trained. So we know what those are, and we know when people go off that things aren't really looking right. Now, there's some that are obvious, like they become gestational diabetic and they're still eligible for a home birth if they can keep that, not go on insulin, right? But if they're on insulin, they're no longer eligible for home birth. That's just, that's what it has to be. So we have these protocols in mind, but we don't have to necessarily follow them. So there's no, oh, you have to dilate this many centimeters per hour, which bodies don't necessarily want to do. And they certainly don't want to do it when they're being watched and strangers are putting hands in their vagina, checking them every 2 to 4 hours, right? So there's that. So that's like not sticking to the protocols. Yet, we also can see we're trained in normal and we're trained in health, like my colleagues just talked about. And a deviation from that isn't like in the movies where, boom, we have to rush you off to the hospital necessarily, or we have to rush you off to a C-section. Can it happen like that? Of course it can. But usually we can watchful waiting to see which way and see what direction it's going in. So it's this weird thing about not having to follow protocols, but knowing when there's a little bit of a deviation. So it feels like it's contradictory, but I hope that made some sense.
It does make sense. Go ahead, Martine.
We all have our own protocols. It's not that we don't have protocols. We all have our own protocols.
Yes, yes.
Based, but we do have some leeway of how we apply it and how we interpret it. And you have to remember, we're starting off doing risk assessment from the time you call on the phone and through every prenatal visit and throughout the whole pregnancy and the labor, the birth, postpartum time, of seeing if that you are staying within safety and within what is normal. So I think that could lead into another myth that people think well, I'll just have a home birth because then I could just do whatever I want,
Exactly. Yeah.
or not totally truthful when they want to transfer and they're like, everything's been fine. And then, you'll get their chart or you'll meet them like, oh, by the way, I have a, an artificial heart and my leg and, or, all kinds of other things you'll find out, when real time comes because they figure, well, they said I was high risk at the hospital, but I knew I could have a home birth because they take anybody, and I could have, whatever else, whatever is wrong with me, be okay. So I think there's a little guidance, and we have a little bit more leeway of how to work with people to get them back to normal or to realize that they do risk out. They're still normal because sometimes you may have to transfer somebody out of your care, but they don't necessarily need an MD's care. They can still have a, safe hospital birth with the midwife.
Yeah. Right. I mean, thank you, Martine. I didn't mean that home birth midwives don't have protocols. I just meant that they're different than what hospitals and birthing centers necessarily have to follow. That's kind of what I meant about that. So thank you for jumping in and explaining.
Right, because just remember, in bigger, larger hospital practices, they take a lot of people in, and in a hospital, it's just the door is open, so anyone can walk into a hospital. Here, you on both sides, the midwife and the client have agreed to work with each other, so there's more leeway to personalize care because you're not taking care of a big bunch of people.
Yeah, the way that I usually describe that is that because they take care of so many people in the hospital, they sort of have to put a fence around the whole thing to kind of corral what's happening in there. And it's part of what they have to do to keep things safe in there, actually, because there's just so many people, so many doctors and such huge practices, and they're sort of just taking people in as they come. And, it's just a lot more complicated what they're doing. Our practices are very small, so we can look at the individual a lot more, I feel, than people can when they work for an institution. Just circling back to a little bit about what we were saying, Kim and I were talking today. She has no sound, but she agrees that that one of the biggest myths that I hear is that people think that if you go to the hospital or you need to transfer, it's because it was an emergency and it's because there's going to be a bad outcome. Does anybody want to talk about like transfer rates, what they really look like, and then maybe somebody else can talk about what a typical, the vast majority of transfers kind of look like?
Yeah, I really like that question. I mean, I've been in practice for 31 years and I've seen 3 true emergencies the whole time. And I'm not talking about a first-year resident walking in and breaking somebody's water when the head is up high and a cord comes out. I'm talking about true emergencies. So when Kristen and I talk to people, we've brought it back to the word complications. And we talk a lot about that's why you're hiring us, because there could be complications at a birth. And so most of our transfers, I mean, you asked the question about transfers. I mean, most of our transfers are so undramatic. They're heartbreaking, but they're not emergent. It's usually a first-time mom who's been in labor a long time, or her water's broken and we can't get her into labor. And we've been there a couple of days with her. She's dilating, not pushing, the baby's not coming. So people think that is a great myth, that people think that when something happens at a home birth, you're screaming, calling 911 and an ambulance is coming. But that's not it at all. You have hired a skilled provider to take care of some of the most common problems, which would be neonatal resuscitation and postpartum hemorrhage, and keep you stable and calm at home. There's a lot to say about that, but I'll stop there.
I'm sure more people will have things to say about that.
So our biggest so Cher and I have anywhere between a 12 to 18% transfer rate at any given time, right? You know, usually like 15 to 18%. And the majority of those are first time moms, what we refer to as maternal exhaustion, right? They just are just wiped out and they want pain relief, or they want to make things go on. And we actually have a code word to talk about that, based on Penny Simkin, which is, which our clients really like this idea, right? Because we tell people, like, you want to say, I can't take this anymore, like I want drug, you know, but when people sign on for home birth, that wasn't what their intention was. But sometimes people get there. So in the 7 years that we've been practicing, we've had 2 non-first time moms have to get transferred. And one was because of preeclampsia, and the other one was because of the presentation of the baby was not going to come out vaginally. They even tried it at the hospital. Anyway, so my point is, if anyone knows about statistics, if we have a, let's say, you know, 15 to 18% transfer rate, and only 2 of them have been second time moms, that makes the majority of them first time moms, which statistically means you have more of a likelihood to get transferred when you're a first time mom, right? So just think that through. So even though that's our rate, that's because that's the whole rate for all of our practice. So when you go into it, if you're a first time mom, think about the statistics being slightly higher, right? So I hope that makes sense. The other thing that I thought you were going to mention, Tanya, when you were talking to Kim about big myths, is that a transfer to a hospital is not a failed home birth. Quite the opposite. It actually shows that home birth works, right? Again, it talks about what Barry was talking about, what Martine mentioned, what I know other people will talk about, is that watchful waiting and individualized care and seeing what direction this is going and what's needed. You know, if I'm sitting and I'm listening to a mom and I'm knitting, I'm taking it all in. You know, I don't have to be staring at her, you know, that kind of thing. So I think that's a big myth too, and that people feel they somehow failed. It's just a different location is needed, or something that we can't provide at home is needed.
I always say, if you transfer from home birth, you know you've done everything you needed before you needed those interventions, versus going to the hospital. You show up, you get Pitocin, you get augmented, or they do other things to you just because you're there, versus that did you really need it? So if you've reached those points, you've done everything in your power, and then you needed a little boost. So you're going there to finish it off. I once had a very challenging pushing phase with someone, and I loved it. Mary Astor, a doula in New York City, she turned around to me when the baby came out. She's like, "That was a failed cesarean, wasn't it?" And I love that phrase. She pushed that kid out.
Thank you, Martine. That's a great point. Thank you, Mary Astor, for saying it and for you to remember it. But those are really good points. And I think, you know, the other thing for people to know is that overwhelmingly, if people do need to transfer to the hospital, that is done appropriately and the outcomes are excellent. So it's not like everybody is almost dead and then we go to the hospital. And I think also one other thing that's sort of the flip side of this that I hear from people a lot is, you know, I'm sure everybody who knows about home birth on this will nod their head, is when, you know, I always say whenever I go to a party and then people say, you know, what do you do? And I go, oh, here we go, you know, and, you know, my kid's school or something, it's not birth workers, you know, and I say, I'm a midwife. Oh, great. Where do you work? Well, I'm a home birth midwife, you know, and immediately, you know, something comes up where they say, oh, that's so great. I would have died if I tried to have a home birth because I had a postpartum hemorrhage. I almost died. And so that's what would have happened to me. And of course, in my mind, I'm thinking you probably wouldn't have died because your midwife would have treated it. But I just read an article today that I was quoted in. This was not my quote. But another person from another state was talking about home birth, and they said that there's no medicine at a home birth. And that's just simply not true. That we carry medicines and we carry other sorts of complementary items to treat things, but we use those things when they are appropriate and needed, and many of them are the exact same thing that they use in the hospital. So I think that that's an important point. Somebody asked a question about whether midwives can administer pain medication and how we manage pain at home. Does anybody want to talk about that?
Sure.
Martine?
I think your perception of pain and how you deal with pain is really different for everyone. Um, Having practiced for 17 years, I think people are ready to try to deal with it. Sometimes it's a real shock to people. In 17 years, um, it's all about a safe birth. I can say I can think of only 3 people from my practice that actually transferred just for pain relief. And that's when you balance, psych ward, home birth, and you have to really listen to people and know that would be detrimental to. Because I always feel like there's a point where you turn around, you think, what was I thinking? I should have been a virgin. I should have never got pregnant. This was a bad idea. And usually you're close and just need a little reinforcement and encouragement. But because of the relationship we build, you know who you can encouraged to perhaps get up and have a glass of water or do this or do that, and needs more encouragement or time, and who you really need to listen to that this is not okay. So I think people are really ready for it. And then we also, in saying that, yeah, some people are shocked by how it might feel, and you give them that safe space that they can cry, they can whine, they can do whatever, and they can just be them. And a lot of times people are able to push themselves through that a hard part for them, and keep going. So pain relief is, first of all, being around people that you trust is utmost important. Being able to move freely. I've had people that say, I'm just going to lie here and not move. But if I was in the hospital and they told me to lie here and not move, I'd be pissed. But to choose what position you want to be in, to get up, if you want to use water, to be around people that understand you and love you, really makes a difference of people getting through it. So no, we don't use pain medicine. Sometimes in very long drawn out early stages of labor where someone is really, really getting exhausted, but they are contracting regularly, but not strong enough to really make a big change. Trying to get someone to sleep. Sometimes people might take a Benadryl and try to get some hours of sleep. Some people might have, because you haven't drank through the whole pregnancy. I always say hospital, they'll give you morphine. Have a shot of that good rum you had on your shelf and see if you can knock yourself out just even for an hour. It makes a big difference to give you that second win. But no, nothing as, no narcotics or anything like that at home.
Thanks, Martine. Does anybody else want to say anything about pain medication or pain management, I guess I should say?
Well, I want to say that is a big part of the reason why home birth midwives really, it's when women come to us earlier in their pregnancies, usually those people, we can prepare our moms, and they can prepare themselves emotionally for coping with labor, because it's at the end of the day, the pain, it's mental, right? Physically, if everything is healthy, the pain is not a sign that something is wrong, right? So it really is a mental game. And when a woman has made the psychological shift to be determined, to set up all the things prenatally to put her in that mind frame of yes, she can, and having that confidence in herself, that is how women are able to do it. And it takes work. It takes birth classes. It takes reading books. It takes building a strong relationship, like Martine said, with your midwives. It takes hiring a doula. It takes, and there's just, it's that psychological shift to be determined to do it. And then it's not that, that there's no way besides medicine to cope in labor. There are so many ways that midwives and doulas are aware of to bring comfort to a person. And someone just being there is the biggest thing ever. Just having someone present in the room that you trust and that believes in you. But there's water, there's massage, there's pressure, there's aromatherapy, the list goes on. So it's not that we just the expectation is not for women to suffer. It's for women to thrive in their, to know that they can focus and they can go inward and they can be going through the hardest thing that they have ever gone through, but that they can do it.
Thank you, Karen. That was great. Yeah, go ahead.
That's the word suffer, and I see that used a lot in childbirth. Suffer means something ill is happening to you.
Mm-hmm.
Labor can hurt like hell or not for some people. Some people be like, oh, that wasn't so bad, or was expecting it to get worse or something. So there's nothing negative happening to you. You feel a crazy sensation that you don't want to walk around and feel every day of your life, but it's not suffering. Suffering is something really ill is happening to you. Is it painful? Yes, but to use the word, and I'm not talking about you, Catherine. A lot of people use that term. It's, I worked med-surg as a nurse before. Those people were suffering. They were dying.
That's why I mentioned it, because there is a difference. And we tell this to our women, where there is a difference between pain and suffering.
Mm-hmm. Big time. And I do see a lot sort of written about home birth in terms of the myths. I see some writings that are out there that say that birthing people are deprived of an epidural at home. And actually, we could just put on our pants and go get one. Like it's, but there's something bigger than that happening for the individual birthing person. And I think that that's what Martina and Katerine and everybody who's been talking about this are really getting at. We have some more questions, everybody, if you guys are up for it.
I wanted to answer the next one. Could I answer this one? What are some ways that midwives can help you move labor along?
Yes, please do.
I love that question. So, how much time do we have? Wow.
Move it along.
We all have. I have to be off in 15 minutes. But we all have so many tricks up our sleeves, and it really depends what stage, what's going on. There's so much information to take in, right? So, just to kind of say that, but we could do things like, again, we could sweep membranes, we can give an enema, we can we can have the woman rest, right? Resting can move things along. Like, who would have thought that? Going to sleep. Martine mentioned Benadryl. Sometimes sleeping. There's a great story on our website for a woman who had a 73-hour labor, and on the second day that I was there to check on her, I made her cry because she was 2 centimeters. And I was like, if you don't get some sleep, you're going to be pulling your hair out. And she cried, crying. And she loves me for it because, 2 days after that, after day 4, she gave birth at home. Crying can help. Journaling can help. Having your great doula squeeze your hips can help. There's so many different things that can, I'm not even mentioning all of them because it's just so exciting. There's so many things. But yeah, so again, there's lunges, there's the mile circuit, there's just so many things. Other people can jump in. It depends what's going on, and it depends what the support is like in the room, what the woman is willing to try. And like I said, what stage she's at. So go ahead, someone else jump in.
I just want to say something really quick. You kind of glossed over it quickly, but not that this isn't exactly the same thing, but I think one thing that we have on our team at home with no real pressure is that we do have the blessing of time. And so that obviously is going to be individual depending on what's happening, just like Carol said, from family to family. But nobody is looking at the clock and saying that we need to clear the bed. So while of course, if you're interested in moving your labor along and you're sick of being pregnant, we're happy to help. But if you want to be left alone and want to be given the time and the space for your baby to come on its own, and you have a lot of patience, that's okay, we do too. So it just sort of depends on you. Okay, here's another question. Oh, this is a really good one, and I know we have some smart people here who can answer this one. I am reading stats that say infant mortality rate is higher with home births than hospital. Does anybody want to speak to the readings that somebody might be finding that says that?
I can speak to a little bit of it. And I'm sure there's just a lot of nuances to that we can talk about, but I'll just mention two. One is that a lot of home birth studies are actually mixing planned home births and unplanned home births. So people who they just happened to have their babies at home because things progressed fast, or for whatever reason, they didn't make it to the hospital in time. And so because a lot of these studies are taken just from birth certificate records where it just says planned or unplanned. So that is a part of it, where you're mixing data of people who had no midwife, no plan whatsoever for a home birth, and they didn't have their a clinician there to prevent that. But also another piece of that is that for us home birth midwives, I think we can all speak to this, is that our priority is both the woman and the baby. Whereas often in institutions, the priority is the baby at the expense of women. So a part of it is that women undergo cesareans immediately to quote unquote save the life of their child. And then the maternal mortality that comes down the line based off of, this woman now having one C-section, now being at risk for having multiple C-sections, and her now risk of her mortality is just not in the picture, because that's down the line. Who cares? We're only thinking about right now. The immediate statistic after the birth. We got the baby out alive. So that's a part of it too, where hospitals prioritize the baby in expense of the mother. And not to say that home birth midwives prioritize the mother in expense of the child, but we are prioritizing both equally, both health equally. I don't know if anyone else wants to speak more to the actual faults in these studies, though.
Well, there's a couple of faults in the studies, and let's just start with that the people who wrote one of the major papers is vehemently against home birth. And you're reading something written by somebody whose intention is to discourage you from having your baby at home. When you take apart the study, there are different levels to the studies, A and B and C, and A is the best kind of information you can get, and it's very trustworthy. A lot of the information that's used isn't on A level. When an obstetrician in her 4th year of residency took apart the studies on home births and looked at the 7 neonatal deaths at home, there were 3 babies of the 7 that would not have, one was a second twin that was born at home with a doctor, so there wasn't even a midwife involved. There was 2 babies born with unlicensed providers, And so when you start dissecting the study, many people have come to conclusion that with a first-time mom and baby, it is safe to give birth at home as it is in the hospital in a well-screened population. And with a second baby, it's actually safer to give birth at home. But it's really hard, even for those of us that have been to schooling and taking classes on statistics and reviewing, to get away from the big capitalized headlines that attract readers. And so that I would speak to that when looking at information about harm. The last piece of that is that when, say, maternal death is recorded, that wasn't part of the question, a lot of times in this country, the maternal death isn't linked to her labor or birth.
That's
and
right.
So we also don't have very good statistics about what actually may happen at the hospital with mothers and or babies. So that's the other piece that needs to get looked at.
Thanks, Barry. And I just wanted to add as well, one thing that comes to mind for me, you sort of alluded to it, but also that they're looking at home birth across the country, and we don't practice across the country. We practice here in New York City. So that means, you know, obviously, different states have different laws around midwifery and different environments in which the people birth. So some people birth at home and they live an hour from the closest hospital, and the only provider that they can find is one in their community who I don't know how much experience they have, who knows. I mean, I'm not saying anything in general about people, but and then, you know, they choose to have a birth that maybe another midwife might screen out as being too high risk. And then also there may not be a friendly environment for that midwife to transfer the person to if they need to transfer to the hospital. Some of those environments are hostile, meaning like if home birth midwifery is illegal in that state, they might arrest that midwife or different things like that. So in any case, I think that there are environments across the country where part of the reason that things are unsafe is because there's no system. And even though we don't have admitting privileges in the hospital, which gets to one of our other questions, what happens here is that you know, everybody in New York lives very close to a hospital, and we all have relationships with the people in the hospital that we potentially could transfer you to. So I hope that that is helpful. Anybody else want to add to that topic? Okay, cool. All right, here is the next question. I've been told that water birth can help with tearing. Is this true? Who wants to answer that?
You know, the thing is that I don't know. You know, I don't keep any statistics. I don't know if the other midwives here, I haven't culled that. Many of the midwives here participate in something called the MANA database, and we record all of our stats in there. But I haven't really looked to see whether water birth helps or hinders with tearing in a first-time mom. About half of our first-time moms need a couple of stitches. But what I can tell you is that being at home compared to the hospital, even though I believe I was a good midwife at the hospital, I see in the last 8 years far fewer tears and far fewer tears that are extensive in terms of women not being on Pitocin or women being on their backs as sometimes they were required to in the hospital. So I don't think about it as much as, are you in the pool? Are you not in the pool? Are you on the birth stool? But it's been very rare to see tears that I saw more frequently in the hospital. And I don't know if any of the other midwives have noticed that.
I think something else to add about tearing. It goes way back also. Nutrition plays a really good part in skin integrity. Not that you're not going to tear at all, but that's why you spend a lot of time, like one of the reasons why you spend a lot of time about nutrition, because that is a really important part. And then also allowing for a slower birth of the baby, as opposed to hold your breath and push as hard as you can, and then do it again and again and again, of delivering a baby slower, I think really plays a big part in that also.
Just to piggyback on what Martine was saying, there are so many reasons, so many things that are at play into a woman tearing. Position, the provider's experience, if there is a need to get a baby out faster, or there's time to wait. Like Martine said, their nutrition, the size of the baby, the position of the baby. There's so many things that are a part of it, that it's not a black and white kind of.
The little babies that like the little thinkers that come out like this.
Exactly.
Little skid marks.
Thank you, Carol. We're all jealous. We'd like to go to the Buddhist meditation session. Have fun. I want to know about it. Okay, I'll talk to you later. We love you, Carol. Thanks for that. And I think one thing that is a myth, I think, about tearing in general is that if you tear, that everything is ruined. Right? That like, if you tear, it's like, if your vagina tears, it's the end of the world. And so, you know, one of the things that I always tell people is that, you know, frequently people, it looks like nothing happened to their vaginas. I always, you know, just joke about like, wow, it looks like nothing happened. And sometimes you have a tear that's sort of like, did you ever fall on the ground and have your hands catch your fall? And you have like little, you know, you have some skinned hands here, and maybe there's a little blood, but you don't need to even put a Band-Aid on it. It's not even a thing. So that happens. And sometimes a little bit more that it's like a Band-Aid. And sometimes you need some stitches, you know? But the chances of you having and even those things people get up and kind of are totally fine with. It's the more extensive tears that Barry was talking about that I think are extraordinarily rare at home. And so I think mainly because our hands are not all up in your stuff trying to get the baby out, which is one of the things that they frequently do in the hospital. And anybody who has any kind of healthcare background is going to know that when we start messing with the integrity of your tissue, it's more likely to tear. And so that's a big reason why that happens in there so frequently. Okay, here's the next one.
I'm going to bring up another myth that I don't know how the other midwives feel about this, but I like everybody to know that I'm a home birth midwife because I love being able to deliver at home, not because I hate the hospital.
Another myth. Yeah, that's a good.
You know, I have worked globally in a low resource setting, and there is nothing better when you need it than a sterile OR and a good surgeon. And that there is a place of deep respect that I have for the hospitals, and we're lucky to have that system here. The system itself is a little out of control, and that's a whole big piece about why the system isn't working. But I attend, if women were and pregnant people and their families were empowered by having their babies in the hospital, by having C-sections, by 80% induction rates, then I would so get behind that. But I I love being able to have these relationships with people, and I have a respect for the hospitals, but home is where my heart is, and I think we can do the greatest work. So that was another myth, that we do this out of fear and hatred, but we don't. We do it because we love this work and love watching people uh, just it's a transformative experience, and to witness that, we are very lucky to do that.
And that's why I said I'm never here to convince somebody. I'm here for people that want to do it. And I think just because you're a home birth midwife, people always assume like, oh, so you're anti-epidural. I was like, I'm not anti anything. I'm for people getting what they need for their birth.
And I think we all have a very good respect for part of the reasons that some of the things that happen in the hospital unnecessarily happen is because they are taking care of so very, very, very many people, especially here in New York. I'm often amazed when somebody, I'm amazed when somebody says, I want the best care, so I'm going to go to the hospital that does the most births on the smallest amount of real estate. You know what I mean? It's like, you're going to get pushed through one way or another. But yeah, the spirit of that kind of thing, it's like we don't have to deal with that in the hospital, at home as well. I'm glad you brought that up, Barry. That is a really, really good point that I think we don't get to talk about so often. All right, so here's a question. What are your thoughts on nitrous oxide? Who's got thoughts on nitrous oxide?
I never used it, so I don't know.
Mm-hmm. So I can say something about it if you want. Okay, yeah. So we know that nitrous oxide under normal circumstances is available, I believe, at the Brooklyn Birthing Center, Metropolitan Hospital, and Mount Sinai Hospital, and probably some places elsewhere. It is very, very, very commonly used in other countries, including the UK. But what I can say is that, as far as I know, there is only one home birth midwife who carries nitrous oxide. So I think most of us, because it really hasn't been used in this country very much, don't have a whole lot of experience with it. And I think anytime I have somebody who comes to interview me who's from the UK, they're shocked and appalled that we don't have it. So I think it's mostly, we've been so slow in this country about nitrous oxide. I don't have any real opinions on it. I've read some of the science on it, and I know obviously the UK has been using it, and the home birth midwives in the UK do carry it. But I think the home birth midwives, generally speaking, here in town, don't have a lot of experience with it, pretty much just like Martine said. I think that answers it. Okay, let's go on. So here is a question. There's kind of two questions about transfers. So one question is, in the event of a transfer to a hospital, does the midwife stay with the mom, or who becomes the delivering doctor? And then a piggyback on that is, if things get complicated, is calling a doctor at home an option, or is transfer the only next step?
I think that varies. I'll take it on. I think for the most part, we all will support our clients by calling the hospital ahead of time, letting them know we're coming, sending your records over so that they also know who's coming in the door, to make it easier for them, but also accompanying our clients through triage. I think everyone has a different practice, but I think the majority of us will accompany our clients. And then depending on the circumstances, we'll either stay or go. Like if I'm bringing someone in and I'm expecting that, where this person's gonna now need to actually be induced for 24 hours, I may not be the best use to them. to be there, but I will come and go. I will be on the phone. I'm still talking to the midwives that I've transferred to. And then at least for us, we always will be there when the baby's being born. Now, if we are transferring because, beyond just pushing the labor forward, if there are other things going on and it's a little bit more complex, and we know that our clients need their midwives there to kind of help with the, like, understand the plan and what to expect in the hospital and how these kind of things unfold, then at least for our practice, we do stay with our moms and dads then, because yes, the people the hospitals and the midwives we transfer to, they do a good job at welcoming our clients and explaining the plan. But when we have a particular relationship with our clients and we know them, we know how they need to hear things and how they need things explained to them specifically. So we stay to be able to help them through that. To answer the second question about calling a physician in. Now, to my knowledge, there's no physician in all of New York City that's going to come into a home birth and help anyway. But I also don't see many instances where they could be helpful in a home setting, where it's something that we couldn't have done, because the reason for us transferring is for usually not necessarily just having a physician, because often we're just transferring from midwives to midwife practices as home birth midwives, but it's more about we need the tools that the hospital has. So maybe this person needs Pitocin, and that should be administered in the hospital because the baby needs to be continuously monitored. Or maybe the person developed a fever. Again, this person's going to need like routine antibiotics, will need their baby monitored, and should be monitored closely. But I can't see what a physician could come in and do that we wouldn't be able to necessarily do. There are some things here and there. Maybe if there were a severe tear that I've heard of other midwives having experiences like that, where they have been trained themselves to do a surgical repair. But really, if we're transferring, it's because we're usually can take care of things at home. So if we're transferring, it's really because we need more than what's just available at home, and not so much the skills of a midwife versus a physician in that setting.
Yeah, I would also say that the training for being at home, I mean, there was a point where I came back to home birth where I just felt like every single person who practices obstetrics should have to have a rotation in home birth. First of all, obstetricians are not even required to take neonatal resuscitation. So, when you're at the hospital, whether you're a midwife or a nurse or an obstetrician, you're used to calling in the team. At home, although our practice and many of the practices here bring either a trained birth assistant or another midwife, you are responsible for doing each of the steps, putting in the IV if there's a postpartum hemorrhage, giving the meds, and these are situations. So I would say that home birth is a specialty, but you need to be trained at home. Although a doctor might be a good surgeon or might be a very patient obstetrician or know how to use forceps well, or has had a lot of experience with breeches and twins, when you have a complication at home, you have a trained specialist in home birth. That's the home birth midwife. And I've known some doctors that do home deliveries. My third baby was delivered at home by an obstetrician. And so, but it really is a specialty. So to call in anyone from the hospital that wouldn't know how to do all the different things doesn't even make sense. And so we're there to handle complications. And again, honestly, the number one reason for transfer is nothing is happening. We're going to transfer to a higher level of care, which means giving Pitocin intravenously most of the time, giving an epidural so somebody can sleep for a while. And so that's how I would answer that.
Thanks, Barry. I wanted to add, it reminded me of a story that of what you were saying about obstetricians and home birth. You know, I love our obstetricians like anybody does. You know, we need them for many things that we don't do as midwives. I don't do surgery on anybody, but I have a close friend that I grew up with who is an OBGYN in Philadelphia. And, you know, we talk about birth quite a bit together. And she asked me, I mean, I've been talking with Birth about her for like the last 10 years. And she asked me just a couple of weeks ago, she said, Tanya, what do you do if somebody has GBS and needs IV antibiotics? And I said, we give it to them. She was like, well, how do you do that? And I was like, the same way that you do. And she was like, well, how? And I was like, well, an IV bag is this big. And like, you know, antibiotics are this big and they're very portable. Like, you don't need to be in a hospital to get an IV. Like, that's just total overkill. So I think, again, like speaking to the myths, people sometimes say, I asked my doctor if I should have a home birth and he said, no, what if you need medicine? So just know that like the OBGYN may have no idea what's happening at home, just like Barry said. And that being said, we're not going to tell him tell him or her how to do a C-section either, because that's not our specialty. We didn't spend years in the surgery suite learning how to do that. Okay, anybody else want to make a comment about that?
Some places, home birth midwives practice also have hospital privileges. Throughout the 17 years, I have had hospital privileges on and off, and that way you can keep continuing to take care of your client if you transfer.
Thanks, Martine. Okay, one more question. Let's see, or what's the next question? Oh, what are the things women can do for home birth? Certain exercises. I'm not sure what that means, if anyone thinks they do. Or maybe this person, Kawai, you want to speak on that? Okay.
Taking childbirth classes will teach you a lot of labor support techniques and tricks to do in labor. And then I always also say it's nice to know as much as you can, but think globally. Most of the world does not take childbirth classes or anything, and they have babies. So it's really trusting in yourself. And I think childbirth classes are, and I'm a certified childbirth educator, so I think they're a great way to build community and to ask questions, or you may not even have a question, but someone else will ask a question that you never even thought of, and you're like, huh, what about that? So I think they're a great way to build community, especially in these days where we live so separate from our families. But it's, you know, building trust, and there are good techniques to learn, and also to include whoever's going to be your support person of how to help a person through labor. I had one partner, he was never had any prenatal visit except like one. And for the birth, he grabs Penny Stimkins' book and is like trying to read through what he should be doing. Like, what should I be doing now? I was like, put the book down. I was like, look at her, pay attention. We do whatever she needs us to do. And so sometimes I think it's the idea that you're relying so much on that you have to learn so much. There are things to learn, and there are things that also, it's, you know, on the spot training too. Like, you have to rise to the occasion. You have no choice, but your baby has to come out, and you will do it.
Thanks, Martine. Here's another question. What would happen if the mother is unable to push the baby out on her own while at home? Is there anything midwives can do to help with the birth of the baby?
Sorry, can I start that one?
Hey, go ahead.
When a baby's not coming out, I always say stop and take a breath and figure out why. You know, is it that the mom is exhausted? Is it that the mom is scared? Is it, because sometimes people don't realize, and in doing home births, I saw if you are fully dilated, that's when you're usually supposed to push your baby out. Some people are not ready yet. And, in the medical model, it's like this magic number that, the baby must come out now. Some people actually sleep and snore and get their second wind and finish birthing after. So if mom and baby are okay, it's okay to wait. And so a baby that's not coming, like we all spoke about, is usually a first time mom, baby's not in the optimal position, the contractions maybe need a little more zing to them or whatever is going on. So if it's not psychological, then you have to look at what are the other factors playing into this baby not coming out. And sometimes if certain positions that babies are in, those just take longer to come out. And a lot of them will come out, but you have to give them a lot more time and watch that mom and baby still are okay. And then you have to know when to draw that line is that they need more help, because either the contractions need a little more zing, or the woman wasn't able to get that second wind to be able to get the baby out. And that's when we would, transfer. And usually, it's like everyone said, it's non-emergency. They'll get up, comb their hair, call their family, we're calling the house, so and we're packing up and leaving. So it's not this thing that you see on TV.
And it's interesting while we're in the car, what happens with the contractions too. They usually slow down, but
Yeah.
anyway.
We talked about if there was a complication, what we call a doctor, but kind of analogous to that. If I had somebody who was pushing and the baby wasn't coming, I would call another experienced home birth midwife to come and evaluate for me. That's another thing that I found in a couple of cases where I needed a second set of hands. So we do use each other as resources. I had a mom whose baby was in a position that wasn't perfectly conducive to her pushing and having the baby come out, and I rallied some of my home birth colleagues and got a lot of good support and suggestions from them. So just to answer, that almost tags back into the last question. If there's a complication, do you call for a doctor? No, but I have many times asked, either through text or phone call or directly coming over, and have gone over for people for other home birth midwife specialists.
Yeah, we do that a lot. Amen. Thank you for saying we're awesome, Sarah Pancake. We appreciate you. Just thought I'd say that out loud. It's not really a question, it's just the truth. Okay, just kidding. Shoko has this question. This, I think, is a great question, because people who maybe have never had a baby or had a home birth before, maybe if they've never had a baby before, and they are charged with hiring a home birth midwife. So the question is, could you share advice on selecting a midwife? And here's their particular situation. They are trying to decide between one with more extensive experience that we didn't connect with as well in an interview, and someone newer in their own practice with whom we felt a stronger connection, and wonder if it's okay to go with the newer person.
I can take this one.
Thanks, Katerine.
And you might kill me for this, but it really depends on you. What we tell people, when I think it was Martine who said that we don't convince people to have home births, right? And in that same vein, the reason why we don't convince people to have a home birth is because a big part of the safety of a home birth is the woman feeling emotionally safe. So whoever inspires that feeling for you, and we're all different. There are women who are very analytical and they love it when we're analytical with them and talking about science and all of that. And then there are women who are more emotionally driven, and they just love us. And then there's just the balance, and then there's people who love the balance of that. So you just have to look within yourself and see with who do you feel safest. And that can be an analytical decision, that could be an emotional decision, but it's wherever you feel, whatever feels right. So there is no right answer for that. In terms of experience, yes, and I'm a newer midwife. I've been a midwife, relative to like Barry, who's been a midwife for 30 years, or Kim, my partner, who's on the call silently, who's been a midwife for a home birth midwife for 10 years. I've been a midwife for 2 years and a quarter, although I've been in the birth world much longer as a birth assistant. And yes, experience is important, and that is why I'm grateful to have an experienced midwife with me. But I think the fact that Kim is so experienced and I'm new brings actually a lot to the table, because we bring different things. She brings a lot in her experience, and I bring a lot in being new, fresh, energized. How she talks about it.
Not as sleep deprived.
I think it's one of those things that you really have to just sit with yourself, just like any other decision you make in life of, do you choose A or do you choose B? And, when you really just sit, you will figure out who's supposed to be at your birth. I once was really ill, and I got to a point where I was going doctor hopping. And, someone asked me what are you really looking for? And I had to take a minute and see it, and really kind of look into myself. What was I looking for? Someone to tell me what I wanted to hear, or someone to tell me, the truth. And it's just kind of the same way. Just like you pick partners for a partner for anything important in your life, you'll figure it out. I would say, I would just suggest, just because this is me, going by someone that's licensed. Most people might be new to home birth in New York City, of the home birth midwives, but they're not new to midwifery. So it's not like, someone that never caught a baby in another setting.
Thanks, Martine. I'll just add, I'm echoing. I'll just add that, I can't remember what I was going to say. Does anybody else want to say anything? Oh, now I know what I was going to say. One of the midwives that we all know, Miriam Schwarzschild, she had a great thing to say about this one day when I was talking with her about when people call her, what she tells them, especially when people call her late in their pregnancies, which is when a lot of us are already booked up. She tells people, just go to nyhomebirth.com. Everybody there is amazing. Call down the entire list and see who's available. Everybody is safe. Everybody is licensed. Everybody is wonderful. And then choose of those people who are available who you feel best with. I don't think anybody here, I can't name a midwife in New York that I don't think would do a great job at your birth if you thought that they were the right one for you. So, I had 2 babies at home. I would definitely, of course you want someone to know what they're doing, but is that the only thing that matters? Yes, of course it's the only thing that matters, but there's more to it than that. So, we're in agreement. Okay.
I don't know. I just real quick, I thought it was really funny what she said. She's like, I picked you and Karen because you seem so grounded, but I did want some frou-frou witchy stuff. So my doula is into beads and whatever. So she got the balance.
Yeah, sometimes your midwife doesn't know beads. It happens. Thank you, Corey. She's gone. Yes, Tanya, we all get a lot of grueling training in our educational process. Actually, since we're on that topic, Thanks, Shoko. Good luck. I think I think it actually will help you. Katerin, I think you thought that wasn't going to be helpful, but I think you gave the perfect answer, really. I think sometimes too, people don't understand the education that midwives receive, who are practicing home birth here in New York. Does anybody want to just, I mean, Katerin, you are the one who finished the most recently, and so you're just very closely in touch with that pain. Do you want to do you want to talk about what the training is like to become a licensed midwife in New York? She wants to unmute.
I'm trying to mute myself. Well, to be a licensed midwife in New York, you can approach it in two ways. You can become a nurse first and get nursing first, and then become a certified nurse midwife and get a master's of science in nursing, or you can have a bachelor's degree in any other field, but then also attend a master's level program of midwifery education, which is the exact same program as the midwives who are certified nurse midwives get. The only difference is that the nurse midwives have to take courses specifically to like the nursing profession. But all the midwifery component is the same. What does that look like? And this might be surprising for people, it's primary care. So we have at least I went to University of Pennsylvania, so we had a whole semester just on primary care, learning about the full body, no pregnancy whatsoever, taking care of people of all ages, from children to very older adults. It included well woman care, so the care, which AKA gynecology. We had full training in that also. So all those IUDs and contraception and any abnormal bleeding and breast health and just women's health in general. And then obviously care of women during their pregnancy and also in birth. And so we really are taught to care for women for their entire lifetimes, from adolescence all past through menopause, including obviously pregnancy and birth. And to and at least for the majority of our education is actually happening in institutions, in hospitals and in clinics associated with hospitals. And I was very grateful for that because I learned pathology really well. But I was also very grateful that I had been attending births with my partner Kim as a birth assistant since 2012. So I was able to walk into the hospital knowing, what things were necessary that I was being taught and what things were just systematically occurring because it became just common practice. But our training is very medicalized. Our textbooks are like, we have a midwifery textbook and then we have a big ass obstetric textbook. And we're learning a lot of pathology. Kim and I like to say when we meet with people who are interviewing us to see if they want to be our clients, we tell them that a lot of the educational programs for midwives don't give a framework necessarily for how to be a good midwife. They give you a good framework how to be a good clinician. But the midwifery piece of that, it's here and there, it's sprinkled. I think it depends on the program you go to. It's all very centered in women and families and people and autonomy. That is everywhere, I think. But what makes us midwives, makes us all so different, is really like up to interpretation and who we are and the things that matter to us. Like for some midwives, they care about herbs. And so that's a big part of their practice. And that's not something we're taught in school, because our training is very medically oriented for a lot of it. And you kind of have to, either you're in a good program that actually tries to involve home birth or community birth, or you have to kind of seek it out yourself, and there may just be like 3 people in your whole class that are actually practicing in community births during their midwifery program. I'll shut myself up now.
Thanks, Karen. That's really awesome. And yeah, so a lot of it we get from the university, and some of it we just have to get on our own. And, you know, we have mentors like Kim, and I had a mentor, Marcy, and who was also my midwife. So I don't know why she did that for me. I already made her stay up all night twice. Okay, so we do have one more hot topic question. Oh, this is a goodie. Is it safe to have a breech home birth? Crickets, crickets, crickets.
It's, you know what, it is safe to deliver your baby with somebody experienced to deliver your baby the way it needs to come out. So whether you were in the home or the hospital with me, it's not safe to deliver a breech baby with me that needs any kind of help and doesn't come out in triage because it's your 5th baby. So, you know, I've done upward of 1,300 vaginal deliveries, and I've been at 2 breech deliveries. So it isn't just about, is it safe for a baby to come out, a breech baby to come out at home? It's the larger question of, who are you? Do you feel safe where you're delivering? Are you with a skilled provider that knows how to care for you? And do they have experience in doing what you're asking them to do? And that's what I would say. Probably many people don't feel experienced doing the extensive repairs that I have done. But that is something that I've really focused on. And there are other midwives that I have deep respect for and have a lot of experience. And if my child was choosing to have her breech baby at home with one of them, I'd be very happy. But that wouldn't be me. So I like to put that question into a broader context, just like, you know, if you ask yourself anything, is it safe to, I mean, this sounds ridiculous and I'm a little tired, and all the midwives here have had 3 really intense weeks with the pandemic going on, but it's like saying, is it safe to play basketball? Well, it's safe to play basketball probably on a basketball court, but not in the middle of the highway. So it's a bigger question than, is it safe to deliver a baby in this position at home? So that's long, but that's it.
Thank you, Barry. I think that is a perfect answer, and we are at the end of our time. So thank you, Barry. Yeah, we're all saying great response, Barry. I was like, who's going to answer the breech question? The answer is, it depends. So we are going to be having these every week on Wednesdays at 7 p.m. with some awesome tired midwives to talk to you directly if you have questions. I imagine we're going to be answering a lot of these types of questions again, maybe from a different angle if you have them. But all of our webinars are being recorded and will be on our YouTube channel, which is NYC Homebirth Collective. If you want to subscribe to us on YouTube, you can also follow our Facebook page, which is NYC Homebirth Midwives. And of course, the link to register for this weekly will be at nyhomebirth.com on the front page. And maybe Kim and I don't know what we're going to talk about on our live next week. So you can find that on our, our webpage. And I just want to take a moment to thank Barry and Martine and Katerin and Nicole Chen, who was here for a hot second, and Kim, who is typing in the boxes, that actually was very helpful, Kim, and Carol, who went to her Buddhist meditation. She's feeling great right now. And all of you for being here, and feel free to reach out if you have any questions, and tell your friends and maybe even your enemies about us. Have a great night, everybody. We'll see you next time. Bye.